Hi, this is Cherry. Hey, I'm just going to get with you for just a quick little bit and talk to you about the real essential down and dirty things you need to know about taking vital signs. So let's start with checking a pulse. That's one of the more frequent and one of the first vital signs that we'll take. As we're doing our ABCs, we'll check a pulse. Now vital signs come later in the assessment when we're actually counting those numbers and we're putting numbers to this. But we're going to check a pulse in our primary assessment in that ABC section. So to do that, we need to know where our pulse is going to be located. And so big factor in that is my patient conscious or is my patient unconscious? Because if my patient's conscious, I know they have a pulse or they wouldn't be talking to me. So it's not quite as critical to know, do they have a pulse? It's more, how good of a pulse do they have? Where with an unconscious patient, my main question is, do they even have a pulse? So with my conscious patient, I'm going to start with the radial pulse, which is on the inside of the wrist on the thumb side, and that's where the radial artery runs. I need to get me a better pointer here. It runs right down here, so you can see it's very much lateral or very much to the outside of that wrist. What you're trying to do is you're trying to press the artery against the radial bone that's in there. And so when that blood comes surging down through that artery, when the heart pumps it out, you're feeling that pulse of that surge of blood rushing down through that artery. Okay. They've got to have a pretty good blood pressure for the pulse to be strong enough that far away from the heart. So when I'm checking a radial pulse, even if I'm checking it just briefly, I'm going to have a pretty good idea, does my patient have an adequate blood pressure or not? If I can feel a pulse all the way down to my radial artery, clear to my wrist, then I know, A, they have a pulse. I know if it's fast or slow, but I also know kind of what their blood pressure is. Okay, so that's the site that we're going to use for a conscious patient. Unconscious patient, we're going to find a carotid pulse. Hold on here, I'm having a technical difficulty. Okay, now if you notice where they're checking this carotid pulse, this is the strongest pulse point on the body. Where they're checking it is not up high by the jaw. There's too much muscle there. Okay, it's down low. It's next to the trachea. So my best way is I go to the trachea and then slide down next to the trachea and put my fingers in next to the trachea. I'm going to run right into that carotid artery. Okay, it's not up high. It's not up by the ear. It's very much in the front of the throat, right next to that trachea. Okay, so the reason I'm going to go there is it's the strongest pulse point of the body. It's the largest artery that can be palpated. So if I'm questioning, does my patient have a pulse, that's my go-to spot so that I can make sure that I am finding a pulse if there is one. If there is not a carotid pulse, then I'm going to have to start CPR. Okay. Okay. I can't find a place to put this guy here. See if I can drag him down here. Okay. Other locations that we can find pulses. The femoral pulse. If you can see over here on this top picture, you can find that. You'll be happy to know we're not going to practice this in class. Okay. You can find that right where the femoral artery leaves the pelvis. So it's very high up in the groin, very high up on that thigh. This is the second strongest pulse point in the human body. The femoral artery is very large. So if for some reason, let's say somebody's doing CPR and you're wanting to check to see how efficient those compressions are, sometimes checking a femoral pulse, you can feel those pulsations when people do compressions, and you know your compressions are adequate then. Okay. Another place is the brachial pulse. And I don't have a picture of this, but it's the brachial artery runs down through your arm. So this is the preferred place on an infant or baby to check a pulse. They don't really have a good neck. Their necks are so tiny, and we may compress their airway if we're feeling around in there. So we're going to go to the brachial, and on an adult, it's going to run right down between that tricep and bicep or pectoral muscle. If you push up in there, you'll find it. It's a little harder to find on an adult, but it is a good pulse to find. Okay. Again, it's the preferred site for infants and babies. Okay. Then we have pedal pulses. They're on one of them is on the very top part of the foot. You're really just going to have to feel around till you find it. I always take a little ballpoint pen and mark an X when I find it. So if I need to recheck it, I know right where to feel. Okay. The other one is on the side of the foot, back by the heel, kind of on that where that Achilles tendon runs, right down in that area. Pedal pulses are hard to find. If they have an inadequate blood flow or low blood pressure, you may not find them at all. Or if they have an injured extremity that is compromising the blood flow, you may not find it. However, if you've got poor blood flow to an extremity that's been injured, you're also going to see it be pale, cool, cold, clammy. It's going to feel and look different than the extremity that's got good blood flow. And the last one that we'll talk about is called the popliteal pulse, and that's right behind the knee. The best way to find this is to put the knee at about a 45-degree angle, and you just literally put your fingers behind the knee and you'll run right into it. And that's a fairly good strong pulse that we can assess from time to time. Okay, so when we're checking a pulse, when we're taking vital signs, not in the primary assessment, okay, when we get down to the vital signs section of our assessment, we're going to find the pulse based on whether our patient's conscious, unconscious, whether they're an adult or a baby, and then we're going to count the pulsations for 30 seconds. Then we'll multiply that number by 2 because what we're looking for are beats per minute. How many times is that heart beating per minute? Okay, you are going to have a watch to do this. I see students all the time trying to use their phones, trying to make them work. Even the like Apple Watches and those smart watches, they tend to go off. And so my students are constantly shaking their arm trying to make them work. You know, sometimes there's just nothing that replaces the $25 Timex from Walmart. And I don't know how you feel about it, but I'm not going to drag my $1,000 phone out in the middle of a call and potentially get blood and vomit and who knows what else on it, or drop it on scene, or leave it on scene because I set it down and I didn't remember to pick it back up. So grab you a cheap watch. You will find it to be very, very useful. Okay. Now what we're going to document on the pulse is the rate, so the beats per minute. Count it for 30 seconds and double it. So if I count 45 beats in my 30-second period, then my patient has a pulse rate of 90. I'm going to double that. Okay. Then I want to know the rhythm. Is it regular? I should be able to anticipate when the next beat is going to be. If it's not, or if I can't do that, I'm going to call this pulse irregular. Okay. And the last thing is the quality. Do I have a nice, good, strong pulse? Do I have a weak pulse? If it's really, really strong, we can attach the word bounding to it. I have a bounding pulse. Okay. So I'm going to document that, for example, like I have here. Pulse is 62, strong and regular. Okay. Or pulse is 45, weak and irregular. I mean, whatever you find, that's what we're going to document. Next thing we're going to look at real quick is the pupils. Pupils are really important because they are the window into the brain. It's often times the only way we have to look in the brain and see how it's functioning. So we see differences in pupils. Oftentimes people with strokes have different sized pupils. People with a head injury may have different sized pupils, or they may have pupils that don't react like they should to light. Typically, when we close our eyes, our pupils are in the dark, so they are going to open up, they're going to dilate to try and gather in more light. So grab your pen light. Please don't use an LED light or a mag light. It's just too bright and you're going to cause harm. But they make really cheap pen lights. They're $1 a piece, I think. And grab one of those, okay, and use your pen light about 6 to 8 inches away. We don't want it too far away. We want that light concentrated in the pupil, but we don't want to leave it in there very long. You're going to blind your patient. So with your pen light about 6 to 8 inches away, have your patient close their eyes for a moment, then open them, shine that light into the right eye briefly. It should constrict immediately, okay? Maybe it won't constrict a ton, but when you see that constriction, you know it's reacting, and that's what we're looking for, is that reaction, okay? Then do the same thing in the left eye. Shine it in the left eye briefly, make sure that it constricts, okay? Then go back to the right eye, shine it in, but look at the left eye. They should work together, okay? If they do, then, and they're the same size and shape and all of that, good Lord, I'm having troubles here, okay? Then we're going to document them as being PEARL, which stands for pupils equal and reactive to light, okay? So don't forget to check your pupils. They're a really good indicator. Sometimes we have a patient that you don't know what's wrong, and maybe they had a stroke. And the only way you're going to find that out, especially if they're unconscious, is to look at the pupils. So pupils are a really good, important vital sign. Another thing we're going to look at is our skin vitals. These are super important because our skin is a really good indicator of when a patient's going into shock. So pay close attention to it and watch it if it changes. Okay, 3 things we're going to look at in the skin. I'm telling you, I'm going through this really fast, so I need you to do a little bit of research on this on your own so that you understand why you're doing it. Okay, first thing we're going to look at is color. When a patient goes into shock, as we're going to learn in chapter, I think, the shock chapter, when a patient goes into shock, their blood will be shunted from their skin. Those little capillaries in the skin are going to shut off, and we won't have good blood flow to the skin, which is going to make our skin look pale. Now, there's lots of different colors for skin. Dig into your textbook and look and see what those colors are and what they mean. Pale is an indicator of shock. Hypoxia, or lack of oxygen, is oftentimes identified by gray or bluish skin called cyanosis. Okay? Yellow-colored skin usually indicates liver failure. Okay, and oftentimes that's associated with cirrhosis of the liver and a few other things. Sometimes we get real red, ruddy skin. It's real red. Oftentimes that's a heat emergency that we're dealing with, or a fever. So there's lots of different colors. Know what you're looking for. Second thing we're going to look at is temperature. Some ambulances do carry a thermometer and they actually take a temperature, but if yours doesn't, then knowing if they're cool, they're normal, or they're hot is sufficient. Okay, and we want to just, best way to do that is to feel the trunk of their body. And I usually just stick my hand in under like the shirt and feel up on the upper part of the chest. Oftentimes the extremities will feel cool, but the trunk part of them may be normal or maybe very hot. Okay, so color, temperature, and then moisture. Okay. A normal skin is pink, warm, and dry. So if it's different than that, let's say, for instance, they're sweating profusely when they're just sitting in the office. We call that diaphoretic, and I've documented that down here on the bottom for you. Diaphoretic means sweating profusely. That's oftentimes a sign that we see in someone that's having a heart attack. So important to note that. Okay. Now, when we look at color, I've noted over here, a young man of African American heritage. Obviously, it's going to be difficult to check his pigmentation or his skin color because he's got the dark pigmentation. So in that case, I'm going to look at either the palms of his hands, or pull that lower eyelid down and look at that mucous membrane just inside the eye. That should be pink. If it's pale, then we're going to call him pale. Okay? If it's pink, you can document that as pink, warm, and dry. I sometimes documented it as normal, warm, and dry if everything is fine. So find what works good for you, but we do need to make sure that we're checking all three of those factors. Okay. Now, respirations. This is where I'm going to get on my soapbox just a little bit. This is by far the hardest vital sign to assess. Okay, it's the one that a good number of medical providers, pre-hospital and in hospital, don't actually count. And I have seen multiple cases where people falsify it. They just take a guess. It's probably about 12, probably about 16. Okay, the normal range for respirations on an adult are 12 to 20. So sometimes if a patient's breathing 24, 26 times a minute, they're not working to breathe. It's not noisy when they breathe. They don't tell you that it's hard to breathe, but let's say it pops up there to 30 or 40 times a minute. Now we've got somebody in a very abnormal range, and everything else looks fine. And if you don't count those respirations, you are not going to realize they're in trouble. So oftentimes that's the first sign that tells you they're in trouble. And if we don't count it, we will miss it. Okay. Now here's the other caveat with counting respirations, and this is perhaps what makes it hard. When a patient knows that you're counting their respirations, they will always change the way they breathe. Now we're going to practice this in lab, and I guarantee you, you can't help but change the way you breathe if somebody's counting. So we have to sneak it in there where the patient doesn't know. So here's how I do it. I grab the radial pulse, I count the radial pulse. Okay? And then just like this nurse is doing with this patient, I'm just going to keep looking at my watch and quietly lay their arm across their chest, okay, or across their abdomen, like he's doing. And then I'm going to count respirations, because now my hand's down close to their chest. I can see and feel chest rise and fall. Now, it's not as easy as it sounds. It's going to take some technique to learn to see that chest rise and fall. Okay. Again, I'm going to count it for 30 seconds, and I'm going to double it. If for whatever reason I cannot see their chest rise and fall, then I'm going to take my stethoscope and say to them, I'm just going to take a quick listen to your heart. And I'm going to put my stethoscope over their chest or in their back, and I'm going to listen to the air move in and out of their lungs and count my respirations that way. Okay? If they think I'm listening to their heart, they won't change the way they breathe. If I say, I'm going to listen to your lungs, they're going to start taking nice deep breaths to help you out, which is going to change the way they're breathing, and we won't get that clear, true picture that we're looking for. Okay, so 3 things we're going to look at with respirations. Okay, very similar to what we're looking at with our hold on here, with our pulses, good Lord, is right down here, rate, rhythm, and quality. So as we move to our respirations, we're looking at rate, count it for 30 seconds and double it. Rhythm, it should be regular. We should be able to anticipate when they're going to take their next breath, unless they cough or talk, something like that. And then quality, I want to know, are they working hard to breathe or not? Are they breathing shallow or not? And do I have equal rise and fall on both sides of the chest? That chest should rise equally on both sides. So I'm going to look at those things and document what I find. Okay? Okay, so let's talk about using your stethoscope. I know this seems really redundant. You think, well, geez, how hard can a stethoscope be to use? You would be surprised. And I have students all the time. I just talked to a nurse yesterday who told me she used her stethoscope wrong for 2 years because nobody ever told her how to use it. And she struggled hearing blood pressures and lung sounds for 2 years until somebody recognized that she was putting the earpieces in incorrectly. And it was keeping her from being able to hear. So when you get your stethoscope, they make cheap ones. You can get them for $6. You can spend $600. Please do not do that. If you think you're going to make a career of this, or you would just like to have a nice stethoscope you can count on, the Littmann, Littmann, is a very nice brand, probably the most popular brand out there. They make a nice quality one. I think $80-$90 you can get a pretty decent one. But when you get it, you need to know that these earpieces are angled. And on the higher quality ones, you can actually turn them and angle them a little bit. But they're angled at about 15 degrees. And the angle of this, if you can see right here in this lady's ears, the angle points towards her nose. Your ear canal actually runs this way. Okay? If you put them in the other way, this earpiece that has the hole is going to go back and just lodge itself into the backside of your ear canal, blocking that hole so you won't hear anything. It's just like having your fingers in your ears. So those go forward. So hold them up, look at them. If when you're holding them up, you can see the holes inside, you have it backwards. So hold it up right straight in front of your face. If you can see the holes, turn it around so it looks like this. And then slide it in your ears and you'll have it the right direction. Okay. This is super easy to do. I've made this mistake myself. So if you can't hear, look at your earpieces. Make sure they're in correctly. The other part of the stethoscope that we need to learn how to use is the diaphragms that we're going to have. Okay. Now, some stethoscopes only have one side, in which case you don't have anything to worry about. Most of them have two sides. Some have like a bell, which is an open kind of concave area, and some have two diaphragms. This, if you can see the other side, has a small, it kind of looks like plastic, but it's not, little film over it that helps to magnify the sound. Most stethoscopes have a small diaphragm and a large diaphragm. Okay, we use the small one for pediatrics because it focuses more on the area on our little teeny kids that we're trying to hear rather than hearing half of their chest. For the most part, you're going to use this big one. But here's the caveat to this. Okay, there is a hole right here in this side. And this little metal piece turns. And when this turns, it's going to turn the hole either up so you can hear through this small side, or it's going to have the hole facing downwards towards that large diaphragm. If you have the hole facing up and I'm trying to listen through this large diaphragm, I won't be able to hear. So when you put your stethoscope in your ear, tap the side that you're going to use with your finger to make sure that that hole is on the right side, or I've heard some people say that their stethoscope is turned on. Okay, and checking that will make sure that you're going to hear what you need to hear. Okay, so to take a blood pressure, I'm telling you, this is going to take some practice, guys. This is an art in and of itself. Okay, so gather your equipment. You're going to need a stethoscope and a blood pressure cuff that will fit your patient. Okay, this particular blood pressure cuff has the cuff here. It's got the bulb on one strand, the manometer, which I've taken a long time to learn how to say that, the meter that measures the blood pressure on the other one, and then your stethoscope. Okay. So to take a blood pressure, now I'm going to post some videos on how to do this that's better than just the pictures of me talking about it. So when you get to your Canvas page, please watch those videos. It'll be worth your time. We're going to ask you guys to start practicing these vital signs at home so that when you come into lab, you'll have the basics down, because we're not going to spend a ton of time in lab going over this. What we want, we're going to give you time to practice it in lab, but we want you to learn it before you come into lab. Learn the steps and the method of doing this. Okay, so when I get ready to put my blood pressure cuff on, it should wrap around the upper part of my arm. It shouldn't cover the whole upper part. It should cover about 2/3 of my upper arm, leaving this inner elbow space, we call this the AC area, free for the stethoscope to fit. Okay, it should fit snugly around the arm with enough Velcro attached that when I pump it up, it doesn't break loose. Okay, there's several sizes of these available. They make them all the way from infant all the way up to thigh cuffs. If for some reason you can't take a blood pressure on the arm, you can take a blood pressure on the thigh, and you can take your stethoscope and listen to that popliteal pulse that's behind the knee that we talked about a minute ago. Okay, so get one that fits you. Some of the larger guys in our classes and some of the larger patients you're going to have, a regular adult-sized cuff may not be big enough for them. Likewise, if you have a tiny little old lady, she may take a child cuff much better than an adult. And so use what fits, okay? The other thing is right here, and on this top piece here, you can see there's a little label there, and it says artery with an arrow that points down. That should be placed right near where the brachial artery is, and that's on the inside, kind of the inside of the elbow there, comes right down through here. So you kind of want that arrow. It doesn't have to be exactly, but you want that in that area so you make sure you're getting a good reading. Okay. Now once we get our blood pressure cuff on, then we're going to start to take a blood pressure. But let's look at this manometer. That word right there, if you can say that 3 times fast, you get extra points in class. I'm kidding. Almost. Okay. So if you look at this, it starts from 0 or from 20 and goes 30, 40, 50, 60, 70, 80, etc. So in between each of these large lines, there is 10 what we call millimeters of mercury. Okay, which means that each space or each line represents 2 millimeters of mercury. Therefore, we should not ever get an odd number when we're taking a manual blood pressure. Okay, because if I hear a blood pressure here, that is 80, 82, 84, 86, 88. That's my 90. And this takes a little practice to figure this out and to coordinate hearing with remembering the number and all of that. So don't think you're going to get this on the first time or the first 10 times you take a blood pressure. This is a little bit time consuming. Okay, so we're going to do some practice. We'll come back to this in just a minute. Okay, the other thing is, here is my bulb that I'm going to squeeze to puff air into the blood pressure cuff. Now inside this cuff is a rubber bladder that's going to fill up and put pressure on the artery. This little silver knob on the side is either going to tighten this so I can pump air into the bladder, or it's going to loosen it so I can let air out of the bladder. Just keep in mind, it's righty-tighty, lefty-loosey. Okay, so tighten it up and then pump. You shouldn't ever have to move it more than a twist or two. So before you start to pump up, make sure you have that valve closed so the air will pump into the bladder for you. Okay. Okay, so we're going to practice this just a little bit. I hope you can hear this. If not, I'm going to post the link to these practice ones on your Canvas page so you can hear them, but we'll talk through them quick. Okay, so pumping up. We're going to go up to about 160, 180, and then slowly let air out. So very gently let air out of that valve. You see it come down. Now this is going to start to bounce. Bounce, bounce. Okay. I actually started to hear a blood pressure. Apparently I can't get there. Started to hear it right about here. So I'm listening for the first boom, boom that I hear. When I hear that first boom, that is my top number or my systolic number. That's the pressure that's there when the left ventricle contracts and swooshes air down that artery, and we get that tidal wave of pressure that comes through. Okay. Now I'm going to continue to listen until I hear the last beat. This one's a little harder. See it bouncing? Right about there was my last beat that I heard. Okay. So I got to go back and figure what that pressure was. Now, if you're not sure what you heard, it's okay to pump that back up for a quick second. Listen again. Okay? I don't want to leave that blood pressure cuff pumped up for very long because it is uncomfortable. And you'll find that out as we start practicing on one another. Okay? Here's another one. Okay. So we're going to pump it up. We're going to go 160, 180. At 180, if you still hear a pulse, pump it up some more. We're coming down. Listen. Bouncing. Boom. Right there I heard my first one. Stronger. And right there was my last one. Okay. So about 90 over 60-ish on that one. Okay. Like I said, I'm going to post some of these for you to practice on. I think these are awesome to practice with because if you do this before you actually take a blood pressure, you're going to know what you're listening for, and it makes it so much easier. Okay. Okay. If we get in a situation like we're in the back of an ambulance and we cannot hear a blood pressure, or let's say we're in such a noisy environment, maybe the jaws are running, trying to extricate a patient, or you're just in a very noisy scene, you may not be able to hear a blood pressure. Okay? We can do what we call palpating a blood pressure. Palpating means to hear. Okay? So when auscultating, palpating is to feel. I'm going to get you all messed up here. So when auscultating or listening for blood pressure is impossible, we can palpate. Okay? Here's the kicker though. It's only going to give you the systolic blood pressure. It will not give you the diastolic. Okay? So what we're going to do is same thing. Put the blood pressure cuff on like we normally would. Put it in the same place. Pump it up. But before we start pumping, I'm going to reach down and feel that radial pulse. And I'm going to keep my fingers on that radial pulse. Then I'm going to pump up my blood pressure cuff until I cannot feel that pulse anymore. Okay? I'm going to go a couple more pumps and then I'm going to start to let the air out. And I'm feeling for that pulse to come back. Wherever that needle is on that meter, when I feel that first pulse, is my systolic blood pressure. Once I've got that, I'm done. That's all I'm going to get. I can let the rest of the air out quickly and be done. Okay? I'm going to document that as whatever number I got. Let's say it's 122 is what number I got over P for palpation. So 122 over P for a palpated blood pressure. This works really nice if you've got a good baseline set of vitals and you're wanting to recheck your vitals as you're going down the road. This helps you know if your patient is staying stable or if their pressure is going up or down without stopping to listen. So it's a nice tool to have, and we use it a lot in EMS. Hospitals not so much because they usually have a pretty controlled environment, which we aren't always privileged to. Okay, so that's palpating a blood pressure. Okay, now like I say, this is the down and dirty. I'm going to post some things on your Canvas page. Please look at it because you need to know how to do this coming into lab. I'm also going to post a practice sheet, and I want you to grab some people, family members, neighbors, classmates. Go to the mall, and those older people that are there walking, if you just say, hey, would you mind if I took your blood pressure quick? They're delighted for that because, saves them a trip to the doctor to get checked out. Okay. So whatever it takes, get some practice doing this. It's going to make you a better clinician. Okay. It's not as easy as it looks, but practice, 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 and we'll get better at it. Okay. So look on your Canvas page for more details and dig into your book and figure out why you're doing what you're doing. And then let's get some equipment and let's practice this so when you come into lab, we can work at getting better and not stumbling through the fundamentals. Have a great day, guys. I hope you learn lots, and we'll talk to you soon.